Hello friends, in this series of non-invasive ventilation, we will discuss about part 5. In this part, we will discuss about the role of NIV in weaning failure, role of NIV while post-extubation from invasive mechanical ventilation, role of NIV in post-operative or pre-operative patients, and role of NIV while doing bronchoscopy. In previous part 4, we have discussed about basics of NIV, how to set, how to apply NIV in a patient. In part 2, we have discussed various interfaces, the role of various interfaces in how to apply mask, various masks we have discussed. In part 3, we have discussed how to troubleshoot when patient is not able to tolerate NIV. In part 4, we have discussed about role of NIV in cases of hypercapnic respiratory failure. But in this module, we will discuss about these 4 things. So let's see one by one. So before going in detail presentation, we will discuss our case 1. This is common patients we used to get in daily life practice. So this is 70-year-old male smoker admitted in ICU and kept on mechanical ventilation because of type 2 respiratory failure. This is common scenario. After 10 days, when patient was stable, patient was able to follow commands, patient was able to protect airway, spontaneous breathing trial was given. But after 1 hour of SVT, patient developed respiratory distress, patient was drowsy, and his PCO2 was raised up to 70 mmHg. So patient was going again into type 2 respiratory failure. And because of this scenario, we have kept this patient on invasive mechanical ventilation. So after 2 days, patient was fine. Again, we have tried spontaneous breathing trial, but same thing happened. Patient again land up in respiratory distress, and we have kept in invasive mechanical ventilation. So this is the common scenario you also used to get in your ICU. So the problem is how to wean this type of patient when you are giving spontaneous breathing trial and patient is getting type 2 respiratory failure. So little about weaning. So what is weaning? Weaning is just liberation from mechanical ventilation. Okay, you are giving spontaneous breathing trial or NIV trial and we are able to extubate the patient. This is the weaning. If you are lucky and you are able to extubate patient in first trial, which is true for 70% of patients, then this is called simple weaning. If first trial is failed, but in second or third trial you are able to extubate the patient or within 7 days you are able to extubate the patient, this is difficult to wean patient. But if you required more than 3 trials or more than 7 days to extubate this type of patient, then this is called prolonged weaning. Okay, so simple, difficult, and prolonged weaning. So, what is the difference and how, for why we have to differentiate this type of weaning? So, this is the study, and you can see this chart. This green part is simple weaning. This is difficult weaning, and this is prolonged weaning. So, you can see if we are facing prolonged weaning, then it causes more ICU stays. Patient need to keep in ICU for prolonged period, and this P was less than 0.001, which is significant. And if patient required more ICU days, patient will get more ventilator associated pneumonia. There's a little difference between simple and difficult weaning, but markedly worsen in prolonged weaning. And same thing, survival. If patient is long in ICU days, patient is getting more web, definitely survival will be low in prolonged weaning. Can you see this one, last one? This is survival for prolonged weaning. So means what is the mechanism of respiratory failure after spontaneous breathing trial? So we should know physiology, then only we can understand pathology. So in case of mechanical ventilation, we are giving positive pressure, and because of positive pressure, patient is being given breath. Okay, but when you are removing ventilator, It means you are removing positive pressure ventilation and patient is getting negative pressure ventilation because we are taking spontaneous breath which is driven by negative pressure. So sudden switch from positive pressure ventilation to negative pressure ventilation, it will cause patient respiratory distress. How? We are giving invasive mechanical ventilation, we are supporting his respiratory system, we are giving tidal volume, so his respiratory muscles are getting rest. But once you are giving spontaneous breathing trial, the the um, the support you are giving from mechanical ventilation you have withdrawn. Now patient has to take his own breath by using his own muscle. Then what will happen? If muscle is good, then patient can wean off. But if patient muscle is not doing well, means there's critical illness neuropathy or critical illness myopathy, or there's diaphragm flattened due to COPD, what will happen? Patient will not get enough tidal volume to support his respiratory system. Once he will not get enough tidal volume, patient will develop rapid and shallow breathing because patient has to take many breath to take his minute ventilation. Patient will develop rapid and shallow breathing, and it will increase workload on respiratory muscles because respiratory muscle has to work hard to get tidal volume from environment. Previously we were giving positive pressure. Now patient respiratory muscle has to work hard to get its mid ventilation. If patient is case of COPD, then because of rapid and shallow breathing, there will be increment in dead space ventilation. And if patient is having emphysema, then patient will have problem of dynamic lung elastance and intrinsic PEEP. Because while expiration, the airway will get collapsed without expelling whole air. Without expiring whole volume, airway will collapse. It will cause retention of air at the end of expiration, and it is called intrinsic PEEP or auto PEEP. And because of auto PEEP, patient will get emphysema and hyperinflation, and it will again cause respiratory distress and CO2 retention. So this is how positive pressure ventilation will cause this problem once you will remove mechanical ventilation. So this is the physiology. It will occur when you are changing from positive pressure ventilation to negative pressure ventilation, and it will affect not only respiratory system but also affect cardiovascular system. How? Because you are switching from positive pressure ventilation to spontaneous breathing, then what will happen? There will be increment of preload, and their decrement and that out that is afterload will also get increase. So preload increases, blood will come in right ventricle, but afterload also increase. So left ventricle is not able to pump the blood. What will happen? Patient will have volume overload. There will be left ventricular dysfunction. So LV dysfunction. Why? Because there is increased venous return and there is large negative deflection in intrathoracic pressure. It will cause LV dysfunction, and later on patient will develop congestive heart failure or volume overload. So at the end of spontaneous breathing trial, because of shallow breathing, because of rapid breathing, patient will end up in type 2 respiratory failure, that is hypercapnia. And once patient will get develop hypercapnia, it will cause uh, the decrement of survival. So you can see this is green one is normocapnia, and that is gray one is hypercapnia. Those patients who are developing hypercapnia at the end of spontaneous breathing trial, they have low survival, around 50%. See, 50%. And those patients who are not getting hypercapnia at the end of spontaneous breathing trial, they are having survival up to 85%. So this is how hypercapnia leads to mortality. So in this weaning failure, how NIV will help? So as you know that in negative pressure ventilation or spontaneous breathing, that muscle is not able to generate enough tidal volume for body. Okay, so once you apply NIV, it will give positive pressure and it will support respiratory muscles. So once patient will get positive pressure ventilation, the respiratory muscles will be relaxed. So there will be reduction in work of breathing because patient is getting enough tidal volume now. Okay, and the large negative deflection of intrathoracic pressure will be reduced because you are giving positive pressure now. And one more thing, by NIV or by CPAP, we are giving external PEEP. And once we are giving external PEEP, it will reduce intrinsic PEEP. So this is the benefit of giving NIV. Okay. So in cases of COPD, where type 2 respiratory failure is there, then NIV is reducing mortality. So there will be mortality benefit in with NIV in case of COPD. But if you take mixed population, mixed population means patients of COPDs are there, neuromuscular disease also there, patient ARDS and any other cause, then there will be no significant reduction in mortality with use of NIV. So in this chart, you can see in case of COPD, mortality is reduced as compared to mixed population. The chances of weaning failure reduced, and WAP, incidence of WAP also increase in case of COPD. But mixed population, there is no benefit. But is every patient will get benefited with NIV in weaning? No. Some patient get failure even after applying of NIV. So what is the cause of NIV failure after extubation? This is lack of cooperation. Patient not cooperative. Excessive secretion, very important. So if there is excess secretion and once you will apply NIV, it may cause dry of secretion inside the airway and it will cause airway narrowing and ultimately uh, weaning failure. Severe strength load imbalance, that the muscles are very weak. Severe critical illness, neuropathy, myopathy may end up in weaning failure and hemodynamic instability. These are the causes which can cause NIV failure even after extubation. So weaning are unlikely to benefit from NIV in around one third of patients. So in one third of patients, even if you apply NIV, they will get fail. Okay. So this is beautiful chart given. Okay. So if there is improvement in underlying indication for which invasive mechanical ventilation was done, then you have to screen daily. You have to check AVG. If AVG is fine, then patient is awake or not. If patient is hemodynamically stable, then you can think of spontaneous breathing trial. Okay. If patient is tolerating spontaneous breathing trial, you have given first SBT trial and patient tolerated well, then you can extubate. There's no problem at all. The problem is if patient is not able to tolerate first SBT trial, mind it, first SBT trial, then we have to assess whether we can give NIV or not. If there is no contraindication for NIV and patient is having chronic respiratory disease and hypercapnia, mind it, patient should have chronic respiratory disease or hypercapnia. We are not talking about hypoxemia. Patient should have hypercapnia. If patient is fulfilling to these two criteria, there is no contraindication for NIV, patient is hypercapnic respiratory failure, then patient can be extubated and after extubation you apply NIV. Okay. If patient is having contraindication for NIV, then we should not apply NIV and we have to give another spontaneous breathing trial and we can extubate after that. If we are not able to extubate patient after prolonged weaning, then we can consider for tracheostomy. Okay, so this is the protocol. So remember with this slide that you can extubate the patient, those who are having type 2 respiratory failure, hypercapnia, not tolerating first SBT trial, and there is no contraindication for NIV. In those patients, you just extubate the patient and apply NIV, and two-thirds of patient they will tolerate. So key point: patient with chronic airflow obstruction have an increased risk of difficult or prolonged weaning, particularly when they present with hypercapnic respiratory failure. The use of NIV to facilitate earlier extubation in these patients is consistently effective, reducing the period of endotracheal intubation, length of hospital stay, and complication rate, and improving survival. So this is the key point for this part. Now, after weaning, coming to NIV after extubation means patient one was on invasive mechanical ventilation, and the role of NIV after extubation. Okay, so after extubation, what is extubation failure? So what is extubation failure? Once you have done extubation, okay, so extubation failure is defined as episode of respiratory failure requiring ventilatory support occurring within 48 hours to 72 hours after extubation. Means you have done extubation, but within 48 hours to 72 hours, patient require reintubation, and that is called extubation failure. And it is as high as one fourth of patient, around 23.5 patient extubation failure is there. Okay, but what is the problem with extubation failure? So this is the study. They have compared extubation success versus extubation failure. So you can see there is more ICU length stay in extubation failure patients. Length of tracheostomy around 55.8% of extubation failure they are end up with tracheostomy. ICU mortality 14%, in hospital mortality 20% as compared to 4.5 and 1.1. So those patients who are getting extubation failure, they require more ICU, they require more tracheostomy, and of course mortality is higher. So treatment of extubation failure: if you are able to find specific cause for extubation failure, then address this issue and patient will be okay. Like if patient is having laryngospasm which causing extubation failure, then you can give epinephrine. If patient is having cardiac ischemia or heart failure, then you can give diuretics nitrate and you have to address cardiac issue. If patient is having stridor after extubation, then you can give helium oxygen mixture or you can give steroid. So by relieving stridor, we can prevent extubation failure. If you are not able to find specific cause, then you can think of NIV. So NIV studies, mixed studies are there, mixed results are there. So in one study, NIV reduced reintubation, but in other study, so in other study, NIV can be given in hypercapnic patients, COPD patients, and chronic respiratory patients, but it should not be used in general population. It means it can be used in type 2 respiratory failure or chronic hypercapnic patient. So this is survival rate with NIV after extubation. So if you see in overall population, so overall population means your ICU mixed patients are there and you are applying NIV all patients, then survival is almost equal as NIV group and control group. Can you see this is almost same. So p value is not significant. But if you apply NIV in case of hypercapnia, then you can see there is survival benefit. So this is survival for hypercapnia, NIV, this dark line. This dotted line is for control group. So you can see marked difference between control group and hypercapnia with NIV. Okay. If you will take hypoxic patient, those patients who are not having hypercapnia, say for example ARDS, then there is low survival with NIV. Can you see this dark one? Low survival as compared to control group. So take home message for this slide, that you can apply NIV after extubation in type 2 respiratory failure patients only. Then only patient will get benefit. So this is algorithm. After extubation, you have to see if any risk factor is there or not. Okay. So what are the risk factor for extubation failure? These are the risk factor. So if patient is having more than one failure of weaning or extubation, patient is congestive heart failure, hypercapnia, or patient have comorbidity, weak cough, stridor, age more than 65 year, heart failure, Apache to score more than 12, acute respiratory failure, obesity, swelling impairment, neuromuscular disease. So patient is having any of this risk factor, then we can apply prophylactic NIV. Means if you see carefully, these risk factors are non-modifiable. We cannot treat easily. Okay. So if any problem is there, you can apply NIV. So after applying NIV, then you have to observe for 48 hours at least. And we have to observe for respiratory failure. If patient is getting respiratory failure, then you should withdraw NIV and you have to intubate the patient and you have to keep on invasive mechanical ventilator. Okay. If patient is fine, patient not getting respiratory failure, then this is successful extubation. And if this criteria is not there, then no need to give NIV. You can put on oxygen therapy and patient will be fine. Okay. So thing is that you have to apply NIV if any risk factor is there. So key point, NIV may reduce the rate of post-extubation respiratory failure, but only for patient at increased risk of extubation failure. We have to see that chart. An important thing is NIV is not effective in treating overt post-extubation respiratory failure. Means after extubation, if patient got respiratory failure, then please don't apply NIV. You have to intubate patient and you have to keep on invasive mechanical ventilation. It will cause more harm if you apply NIV. So NIV is for prevention of post extubation respiratory failure, not for treating respiratory failure. Keep in mind, very important point. Now coming to our third part, that is prevention of post operative complication. So we know that in every surgical patient, around 10% or surgical patient, they are landing in respiratory compromise, and 40% of patients, those who are undergoing abdominal thoracic surgery, they are having respiratory compromise. So what is the pathophysiology, why these patients are getting respiratory problem? So main problem is anesthesia. As we know our MBBS days, that anesthesia is causing basal atelectasis, and it causes reduction in FRC, functional residual capacity, and transient diaphragmatic dysfunction, which lead to hypoxemia or hypercapnia. So basal atelectasis, reduction in FRC, and diaphragmatic compromise. This will lead to respiratory problem. Another thing is, then you have must seen that in while surgery, that people are giving more fluid. So some patients, they are getting perioperative fluid overload, especially those patients who are having cardiac dysfunction. Patients receiving high tidal volume during surgery, trali, patient is getting blood, so it can cause volume overload, and patient may have risk of aspiration. So these are the causes which can lead to post-operative respiratory complication. So how NIV help this type of patient? So if you apply CPAP means constant pressure while inspiring or expiration. So it will help to maintain the upper airway patency. Those patients who are having obstructive sleep apnea, it will help. And it is giving PEEP or CPAP. So it will not allow alveoli to collapse. So it prevent basal atelectasis. So it will improve functional residual capacity. It may improve left ventricular function, and if patient is having COPD, it can reduce autopy. Okay, so this is function of CPAP. If you are applying BiPAP, so this benefit is there, CPAP benefit is there. Along with this benefit, it will give support to respiratory muscles. It will augment tidal volume. So it increase alveolar ventilation and respiratory muscles unloading. It will increasing tidal volume. So what are the indication? So indication may be preventive indication. Preventive for what? Respiratory failure. So post-operative patients, they should not get respiratory failure. To prevent respiratory failure, we can apply NIV in patients, those who are having acute respiratory failure. Say for example, obese patient, OSA patient, chronic lung disease, congestive heart failure. So these patients we can apply NIV to prevent respiratory failure. And if patient is having thoracoabdominal surgery, cardiac surgery, bariatric surgery, in this patient also we can apply preventive NIV therapy. So whenever you receive references for fitness of respiratory problem, you are getting references no from the West department. So if you are getting references for fitness or surgery, then you have to assess whether any risk factor is there or not. If any risk factor is there, patient is obese, patient is OSA or these things, then you can advise that patient may get post-operative NIV to prevent respiratory failure. Okay. So these are preventive. Therapeutic means those patient who is getting respiratory failure after surgery. Okay, so post-operative acute respiratory failure, post-operative pulmonary edema, and post-operative airway obstruction. So in these patients, we can apply NIV. Contraindication. So contraindication is same for any NIV. It is not particular with this surgery. Any NIV like impaired consciousness, acute myocardial infarction, copious secretion, upper GI hemoptysis, facial trauma. These are the same for all NIV. Relative contraindication, patient uncooperative, acute ischemia, pregnancy patient. So this is same for all patients. I'm not going detail. So key point in post-operative patient. So peri-operative cases most likely to benefit from NIV are high-risk patient with COPD, cardiac failure or obesity, and those undergoing high risk procedure like cardiac, thoracoabdominal and abdominal surgery. So in this type of patient, we can give preventive as well as therapeutic NIV support. So coming to our last part. So let's see this case. This is 27-year-old male and patient have 5 days fever, develop hypoxemia. Patient at present having 95 saturation with 10 liter of oxygen, and you can see that in x-ray the diffuse infiltration. Okay, patient not responding with antibiotic. So what do next? So obviously we have to see the specific microorganism for treatment purpose, because if you will give exact treatment, then only patient will respond. So we need to do BAL this patient, we need to do bronchoscopy. But will you do bronchoscopy because patient 10 liter oxygen, even 10 liter oxygen, patient maintaining just 95% saturation. Okay, so we can do bronchoscopy with the help of NIV. So what is the risk factor while doing bronchoscopy in hypoxemic patient? Okay, patient already having hypoxemia. So if you take BAL, then it will cause reduction in surfactant, and reduction in surfactant will cause alveolar collapse. If you do strong suctioning, then it may also augment lung collapse. And introduction of bronchoscope, it will reduce diameter of airway. So patient will have increased airway resistance and of course work of breathing. Okay, so how NIV help? So NIV by giving PEEP or CPAP, it will recruit lung tissue. It will open up collapsed alveoli. Okay, reduce the work of breathing by application of inspiratory support. It will increase tidal volume. Okay, So when to use NIV in bronchoscopy? We can use before procedure to pre-oxygenate the patient. It will increase respiratory reserve. During procedure, it will help in alveolar recruitment. It will reduce decruitment or increase increment. After the procedure, if patient is hypoxemic, we can give NIV after procedure also to increase patient recovery. So this is 3 times we can use NIV while doing bronchoscopy. So when to use? What are the cutoff value where we should apply before bronchoscopy? If there is marked hypoxemia, PF ratio less than 200, then we can use NIV while doing bronchoscopy. But we don't know what is the safe lower threshold, because below 200 we should apply NIV, but the lower limit of this we don't know. Okay, so what was adverse reaction while using NIV? With the NIV, patient may get gastric hyperinflation, because NIV is pushing air not only to airway but also to esophagus and abdomen. Okay, if patient is having severe or persistent hypoxemia, it can cause respiratory distress and patient may require endotracheal intubation. Cardiac complication, though it is rare, but it can happen because of secondary to development of hypoxemia. So these are the problem. So for bronchoscopy, there is special type of mask. So this is extra port. By this extra port, we can insert bronchoscope by this port. Okay, or in traditional NIV mask, we can use this L-shaped connector. Okay, so by using this connector, we can insert bronchoscope through this part. We will attach NIV by this port and we will insert bronchoscope by this port. You can see this port. We can insert bronchoscope. This type of connector is available. So you can see this is ordinary mask and this L-shaped connector is applied here. And by this connector, we can insert bronchoscopy and we can do bronchoscopy preferably by oral route. Okay, so that's all in this module. So we will summarize with this guideline, official ERS ATS guideline for NIV. So we will summarize. So first question, should NIV be used to facilitate weaning patients from invasive mechanical ventilation? So answer is yes. We can use, but remember we have to use in hypercapnic respiratory failure only. So guideline doesn't recommend for hypoxemic patient. Second question is, should NIV be used to prevent respiratory failure post extubation? Again, yes. For high risk patients post extubation failure, we can use NIV, especially in type 2 respiratory failure. But remember, if patient developed respiratory failure, then we should not use NIV. We have to intubate. So this is for prevention part only. Another question is, should NIV used in treatment of respiratory failure that develop post extubation? Big no. Once patient develop respiratory failure, we should not use. Should NIV used in acute respiratory failure in post-operative setting? Yes. For prevention also and for treatment also. Prevention for respiratory failure. And patient develop respiratory failure, we can use NIV. Okay. So my last take home point. So every patient is unique. So decide NIV versus invasive mechanical ventilation wisely. Because if you see guideline, all are conditional recommendation. See conditional recommendation. So guideline is evolving because new literature is coming, guideline is changing. So use your decision wisely, because NIV has narrow therapeutic index in especially in ICU. So if you are using NIV, you should remember, then you should not prolong NIV support. If patient is getting respiratory distress in spite of NIV, you have to intubate, you should not wait. If you will wait with NIV, then it will increase mortality. So with this, thank you very much. So previously I have made this 4 YouTube video on non-invasive mechanical ventilation. So I strongly advise go through these lectures and you will understand better. See you with new lecture. Thank you very much.